Hello everyone, we continue with our review. My goal is to give you the most high yield informations in the questions that lead you to the right answer, okay? So this is what we're gonna do. We're gonna continue our discussion of the cardiovascular system, okay? So let's see, okay, you should get 71-year-old woman came in with shortness of breath and dyspnea, okay? So, okay, now you go to the physical exam or cardio or test finding, okay? So you do echo, you find EF 65%, okay? That's kind of give you an idea. Maybe there's half HFpEF. You check the pulmonary artery systolic pressure. It's 50, okay? So it's a little bit elevated, right? So now the question is, what could improve the quality of life in this patient, okay? What improve quality of life, okay? Exercise, training, definitely improve the quality. Anytime you see exercise, this is good answer, okay? So this is HFpEF, just like we discussed about. You want to focus, the medications that improve mortality is spironolactone and dapagliflozin is GLT2 inhibitor. Others, Lasix, blood pressure control, AFib control. You know, this is the management for HFpEF. So HFpEF management question. Okay. Let's do another question. Let's see, let's say you got 45-year-old man, okay? Came in with dyspnea and diaphoresis. Started this morning, okay? So what do? You examine him, okay? You do exam. On exam, you see early diastolic murmur at the left sternal border, okay? And then you do the vital signs. Patient have fever, okay? Echo shows 7. You order echo, right? You see murmur, you order echo. You see 7 millimeter mobile echogenicity. So this could be an abscess, right? And the patient having crackles, right? Crackles on exam. So now they're asking you, what's best next step is cardiac surgery, right? And not that the question. They said, what are the indications for cardiac surgery in this patient? What are the indications for cardiac surgery in this patient, okay? It's because they want you to know what are the indications for effective endocarditis management. So this patient, because he has crackles, has some dyspnea or shortness of breath, this is signs of heart failure. Okay, so that's the answer. Now this brings us to the discussion. What are the indications for early surgical management of native valve infective endocarditis? 3 things. Number 1, if there is a valvular or conduction failure, like if there is heart failure due to valvular regurgitation, if there is valve leaflet fistula formation, if there is a new heart block, okay? Others, uncontrolled. Second thing is uncontrolled infection. If there is a perivalvular abscess, if there is infection that's difficult to treat pathogen, like fungi, okay? If there is persistent fever or bacteremia, even after 7 days of antibiotic therapy, okay? So that's the second one. Third thing is embolic complications, like if there is systemic emboli despite appropriate antibiotic therapy. Other things, if there is left-sided mobile vegetation more than 10 millimeter and a prior embolic event. All of these are indications for consulting cardiovascular surgery. Hey, come, I think this needs surgical intervention. You can't just treat it with antibiotics. These mean like failed antibiotic therapy, there is some heart failure, could worsen, you know. So you just gotta intervene surgically, not just antibiotics. Okay, another case, you see 75-year-old man with lightheadedness. Lightheaded, right? And dizziness. So as expected, you check, you do exam, you do echo. Okay, so an exam shows late peaking systolic ejection murmur, and echo shows calcified aortic valve, and then gradient across aortic valve gradient is 50, right? Is 50. So now you gotta know, is that high, is that low? So this is, so 50 aortic valve gradient is 50, it's pretty high, okay? So now the question is not that, okay? Need some intervention, needs some cardiac surgery. We discussed that earlier. That 50 needs some intervention, right? So now the question is, why do you do heart cath? Why do we do heart cath before surgery, huh? That's our question. And the answer is to define coronary anatomy. Okay, that's kind of important. You define the coronary anatomy before you do the discharge. So this question, you want to define the coronary artery anatomy. Why? Because 40% of patients who they may need coronary artery bypass graft, and there's risk for embolization if you don't make sure the coronaries are fine before you replace. You know, there's risk of embolization, to have a stroke. You know, it's not good stuff. All right, another case. Okay, let's see. 45-year-old. Let's go. 45-year-old. So you got 45-year-old comes in with palpitations. Man comes in with palpitations. Treated with metoprolol, diltiazem, flecainide, AFib. Okay, which is expected. Okay, and then the question is, what's the best next step to maintain sinus rhythm in this patient? The best way to maintain sinus rhythm. Okay, this patient, what you want to do, you want to do transcatheter ablation procedure. You want to do ablation, okay? Because the patient has been on a lot of medications. Despite being on a lot of medications, still require require ablation, still having AFib despite on being on diltiazem, flecainide, you know. So you want to do ablation. That brings us to the discussion of atrial fibrillation management. So the way you manage atrial fibrillation, if there is no coronary artery disease, or if there is no coronary artery disease or no structural heart disease, you do flecainide or propafenol. If there is left ventricular hypertrophy, you do dronedarone and amiodarone. If there is coronary artery disease without heart failure, you do sotalol or dronedarone. If there is heart failure, you do amiodarone and dofetilide. If it's refractory, you do ablation. In a clinical, usually you give amiodarone. I've seen sotalol used for coronary artery disease. But these are usually started by cardiologists, like flecainide, sotalol need a lot of monitoring, flecainide need a lot of monitoring, even ablation. So this is like kind of, but just you've got to know about it. Okay, so that's kind of brings us to this discussion.